Now that's stage 1. Let's talk a little bit about stage 2 adolescent domain. Now, it's important to realize that these stage 1 engagement, motivation, you're going to do that throughout therapy, right? There's going to be ruptures to the alliance, things will happen. It's something that has to be nurtured throughout. But now we've got to get into stage 2 and make the changes. And again, we think of domains, changes in the adolescent, parent, family, community. Again, another cartoon from the child. How am I supposed to think about consequences before they happen, right? The adolescent brain just doesn't go that way, but we help them. Our goals in stage 2 adolescent are generally, as I mentioned before, self-awareness, developing life goals, emotion regulation, coping skills, communication skills, and enhancing a sense of personal agency, that they in fact can make a difference in their life, can make it better for themselves in school and with their family. And how do we do this? How do we achieve these goals? Well, we spend some time with the youth helping them examine who themselves. We often say who you are now, it's kind of a pause in time, we're in therapy, who you were before and who you want to be tomorrow, next month, next year. We brainstorm life options together. We help the youth identify forces both inside of him and outside that drive him or her toward risk or self-destruction, and also to the healthy places. We explore consequences, both positive and negative, of past, present, and future risky behavior. We don't deny the positive consequences. And we examine ambivalence to change, barriers to change. And this is done over multiple sessions. We help them develop healthy goals. We're asking the child to change, to stop using drugs, to go to school, to stop hanging out with these friends, to be more respectful at home, whatever it is. But they have to have a reason to change because, again, they're getting something out of this life they have. And so they have to have a reason. And early on in the therapy and throughout, we're going to help them develop the reason. We help them have dreams, wishes, dream big, have aspirations. We'll do research with them on the internet and field trips to support those dreams and goals. We have to show that we believe in their dreams and goals and, of course, encourage them to share these with their parents, which is really important because a lot of times the youth doesn't share with the parents, and the parents may think they don't care about anything when, in fact, they do. And it can really change the dynamic between the parents and the youth. And then this is very important, and this work will be done alone with the team, is we draw discrepancies between the goals and the dreams that we've talked about and their current self-destructive behavior. And of course, you have to spend some time developing the dreams and the goals and who they want to be and all that. And then, but then it's not as if they start therapy and boom, they stop using drugs. It's a process, it takes time. And so as we're having the conversation, the discrepancies go something like this. Well, that's kind of interesting. You tell me you want to graduate from high school, you want to get probation off your back, you want to own a business, you want to go to college, you want to be a auto mechanic, all cool stuff. But then something doesn't make sense because you're still using drugs, you're not going to school, you're still hanging out on the corner. How are those things going to bring you to all these goals? And so you start to challenge. So it's something like, does that mean you didn't mean it when you said you don't really want to graduate from high school? That you didn't mean that? Is it too hard? Is it? And then you start the discussion of really challenging them about the discrepancies between the goals and the dreams, which are usually real, and then the self-destructive behavior. And that can move us more, get them stronger in the commitment to change, and then allow us to help them with the tools to make the actual change. So that's really important part. And obviously, I'm just going to go through some of these fast because we're going to have a break soon. We're going to help the youth believe in themselves, right? You have your dreams and goals, but then we have to help them believe that they can actually achieve them. We're going to develop strategies to reduce self-doubt. We're going to encourage parents to support them. We're going to have discussions, very problem-focused discussions about how to get where they want to be, how to take charge of their life and make these changes happen in the family and also in their life in other ways. Concrete behavioral plans to promote change. We're going to teach tools. We're going to help them put it in action while they're in therapy. Now, one area, as I mentioned earlier, that youth can really change is how their parents treat them. And so we're going to prepare the youth typically in individual sessions, not only to understand themselves better, but also once they understand themselves to express their concerns and opinions, feelings to their parents. Many teens feel misunderstood. And we'll help them to effectively communicate, decide what to say. We may even give them lines and rehearse and give confidence, help them clarify their ideas. It depends what the child needs, but they want to say things to their parents, and we're going to help them identify what those things are and give them the skills to do it in a way that the parents can hear them, which is, typically not blaming and demanding. We're also, with many of our teens, they need help with emotion regulation, coping, communication skills. We have an MDFT way of dealing with anger and upset. We don't allow the children to feel that they have an anger problem. We try to let them know that there's no such thing as an anger problem. It's an emotion, and some people are quick to anger, and some people are slow to anger. And what's important is to understand what makes you angry, how to control your anger or your emotions that get in the way, and how to put it into words so that others can hear you and change. So we work a lot on that if they need it. Many of the youth we see do, not all, of course. Now I'm going to talk a bit about drugs because they're special in some way. We don't think of it as a moral issue, good or bad, or a disease. It's just a pattern of choices, circumstances that happen over time that become a habit that's very hard to break, as we all know. They especially worry us with teens because they can make the youth unavailable to themselves and incapable of thinking about their lives. And as you just heard, we spend a lot of time challenging and helping the youth think about their life and who they are and who they want to be and having some sense of agency and control and not just being a victim, but being an active player in their life. And so the drugs makes it's a challenge. And we use urine testing not in a way that a probation officer or employer would use it, but in a therapeutic way to open up the dialogue about drug use. So it's not, yes, I am, no, you're not, you aren't. We don't want that back and forth. We want to deal with it. In MDFT, we also have specific guidelines and protocols for common issues that come up with youth. I've already mentioned substance abuse, emotion regulation, trauma. Many of our youth or parents have experienced a lot of trauma that hasn't been dealt with. Mistakes, slips, and relapses. Again, it's not a linear line to recovery. Depression, anxiety, and other special issues that may be important for our youth and families. Now what I'd like to do, I think it's time for a break, and this is a good time for a break, and then we'll continue. And please write in questions, because I'd like to be able to address some questions when we come back from the break.
Great. Well, we will reconvene at 11:10. right, everyone. We are back from break, and I do have a few announcements to make before we get started again. And also, several questions have come in, some great ones. So I just need to remind you that 2 CEUs are available for those that participate in today's webinar for the full 2-hour presentation time. You must have audio and on-screen visual to qualify for CEUs. When I exit the event, your browser will take you to a brief evaluation form on the FADAA website. We value your input and hope that all attendees will complete the brief evaluation. This next section is important. Most of your questions as attendees are answered in this section. To receive a certificate of attendance for this event, please complete the evaluation. If you attended the entire webinar, your certificate of attendance will be delivered to your email address within 5 days. Also, a PDF copy of the PowerPoint presentation will also be sent to the email address you provided, and a recording and slides of this webinar will be available at www.fada.org. For FADAA to report your CEUs to CE Broker, please provide an accurate Florida license prefix and number. Okay.
Oh, I'm sorry.
We're ready to begin.
So what I'd like is to address some of the questions that have come in. So how should we do that, Elizabeth?
Well, I have several, and some of them relate to each other. So we'll start with the first one that we got. What about comparison to services other than group therapy? Group therapy is not really a typical intervention for high-risk children and families.
Okay, thanks for that question. MDFT studies have been compared to treatments other than group therapy. There have been a couple studies that compared MDFT to individual cognitive behavior therapy and also to multifamily group therapy and even residential treatment. So the comparisons have been kind of diverse, and in every case, MDFT does as well or better than the comparison treatment, so not just group therapy.
Great, okay. Here's one. How do you advise proceeding with clients who do not want to involve parents in sessions?
Okay, so when you say clients, I'm imagining you're saying youth or teens don't want their parents involved. Again, it's all in the way that you talk to the child, the youth, with respect and dignity and the intervention of there is something in this for you. So the issue is that the only way to get the parents to treat you better, to give you a better deal at home, is to talk to them, to work with them. And so usually when the teen, we form a really strong alliance with the teen, and they know that we're on their side and begin to trust us. And then when the therapist says, the only way to change your parents is by me meeting with them and us meeting with them together, and I'm going to help you through this, and they go along with it. We never, all these years I've done it, thousands and thousands of cases, we've never had a situation where a youth refuses to involve their parents.
I now have two that are related. One is, what about comparison to services? Please eliminate the parameters on how the approved urine testing is handled so that the obvious guilty is not in the forefront. And also, can you explain further not using urine testing in a law enforcement type of way? How do you go about using it in a more therapeutic way?
Yeah, that's a great question. And I can't give all the details. We have specific protocol. But for instance, we don't watch the child give the sample. We don't, blue the water. We don't do it in that. And so we might have inaccurate testing. That's okay. We're using it to open dialogue. We usually use the instant test That's really important. You don't want to send it out to a lab. You want right away. We sit with the youth and watch the results come in, and then it's a matter of discussion. He says, well, I'm not smoking weed. Well, but you're positive. I'm not using cocaine. Well, okay, let's talk about this. And again, it just, you don't have to get into this fighting. You are using, you're not using. The test says, the child may still say, I'm not. You just proceed. And the idea is to, to open the dialogue. It's not we're not going to tell their parents. We're going to encourage the teen to tell their parents with us present because, again, we think that's going to help in the dialogue, but we're not going to force it on them. Again, most do. And also the idea is we're going to catch them being good. So sometimes the parents think the child is using more than they're using. And so, well, you're positive marijuana, but your parent thinks you're using cocaine. Let's show them, let's talk to them about how they're not doing that, you're not using that. So, and also as kids start to cut down, they're really excited to be tested to have a clean test. So it's just about dialogue.
Here are a couple more that are related. What is the overall time frame of the treatment? Given that the drive for short-term work is the push and makes insurance happy. And a second, Can you please speak more to how this model can be best used in a residential treatment center? We typically only have 30 to 45 days with some families and 90 if we get insurance approval. Any thoughts on how to use incentives or motivate the client when they are in residential care?
Okay, let me ask those two questions, and we'll talk more of this later on. The treatment is typically 4 to 6 months. Pretty intensive, 1 to 3 times a week, usually twice a week, and it depends on the setting. In an outpatient program, you might be limited to office space once a week. In a program that can be in-home or hybrid in-home and office, you can have sessions in the home and in the office, and it could average about twice a week. MDFT is, I always like to say, it's an intervention, not a service delivery system. And it can be used with pros and cons, strengths and weaknesses in a variety of service delivery settings. And our organization, MDFT International, works with organizations, service delivering settings to make it fit with their program. In terms of residential, sure, 30 to 45 days, it's not the best. We all know many of our children need longer. But I'm sure MDFT could be brought in that setting. What we do have now, there are programs in Connecticut and in the Netherlands, residential MDFT programs. So the one in Connecticut, it's 4 months. It's very strictly 4 months. They have to be gone out after 4 months, and then they're discharged typically to community MDFT. In Netherlands, they have 4 and 6 month programs. They also have brought MDFT into prisons where the child could be incarcerated for 9 to 24 months.
Okay, that's the bulk of them, but I just received one more, if you would like to answer it.
Sure.
Okay, every state is different, so I know I always have to check each state's regulations that I'm licensed in, what they accept and from whom and what agency and how they are approved or accredited, or if they applied for approval.
I didn't hear the question. I don't get the question.
Maybe it was more of a statement. The last sentence was off. Well, we can move on from that. That is the bulk of them.
Okay, we'll move on, and there'll be time for questions at the end. So we've talked about stage 1, alliance and motivation. We've talked a bit about some of the interventions in stage 2 with the adolescent. And now let's talk about stage 2 with the parent. Now, one thing to realize is although I'm talking parent, adolescent, one at a time, in MDFT, you're intervening in the parent domain, in the adolescent domain, in the family, the community at the same time. And we have individual sessions with the youth, individual sessions with the parents without the youth, and then family sessions, and sessions often with parent, youth, and probation officers, teachers, and the like. And part of the process of learning MDFT is deciding on when to do, what to do when. But let's talk about kind of our general interventions with the parents. Again, a cartoon. The plea of many parents, the desire, the dream is, young man, go to your room and stay there until your cerebral cortex matures. That would be great, but that doesn't happen, and parents have to do their best. There are lots of resources about parenting and parenting adolescents. I have one up here. There are many. And in general, we know that the parents need to love and connect, monitor and observe, guide and limit, model and consult, and provide and advocate. And what you do for a 5-year-old is not the same as what you do for a 16-year-old. So it can be quite a challenge for parents. What we do in the parent domain. Well, first of all, we're going to support these parents as parents and human beings. We really empower parents, and we show compassion for their struggles and effort and experience. We disabuse them right from the get-go of thoughts of blame, guilt, shame, embarrassment, which are often feelings that they have. We emphasize self-love and self-care. You've got to take care of yourself in order to take care of your family. Kind of the image is when you're on the airplane and they say, put your own oxygen mask on first and then help your child. And we're going to validate their past and current parenting efforts. I mean, some things aren't working, and we're going to help them stop doing things that don't work and try ways to influence their youth that do work. But everybody does a lot that does work, and we want to support that. I want to focus a little bit more on that second item, disabuse them of thoughts of blame, guilt, and shame, because many parents deep down do feel this. Because our society, in some way, we tell parents, we communicate in many ways that if your child is doing well, then that means you're a great parent. If your child is struggling with substance use, mental health, educational problems, then that means you're a lousy parent. And that's just not true. Parents are an important part of the solution, but they are not the cause of the problems. And it's really important. Usually I do it right in the beginning, session 1 or 2, and I just tell them, you know, it's not your fault, and this is why. And we're going to work together to help your child and you, but you are not to blame. Just because that can just get in the way of the parents being open to changes. We're going to empower parents, and MDFT therapists in training hear this word all the time, empower, empower, empower parents. We're going to identify what they want for their child and family. We're going to examine their ambivalence to change, have them understand that, empower them with knowledge. Some parents just don't know, and confidence with skills and feeling competence. Really important. You need to feel competent in order to try new things. And if necessary, we're going to enhance their individual functioning. Some parents need themselves use drugs. We have to help them with that. They may have mental health issues that aren't addressed. They may have physical problems, and it's really important, again, to empower the parents in every way. When you have more than one parent who's involved, and I use the parent broadly, this could be a step-parent, a boyfriend or a girlfriend of the parents. It could be grandparents. It could be the biological father and mother. You know, you're going to get a sense of it. When there's more than one involved, and sometimes it can take a little while to figure out who is involved, there are always going to be differences and disagreements in how to parent and influence their children. And you have to address that right away. That's one of the first moves in the parenting domain, is to figure out who's kind of in charge, how they want to work, their different roles, how they want to be a team. So a team could be equal co-parents, or it could be that one is more in charge and the other isn't. It could be that they have different roles and responsibilities. There are a host of ways that parents can parent. And again, as I mentioned, we're not the parent police. We give them knowledge, but we help them figure out what's going to work best for them. And so in the teamwork early on, it's figuring out the roles and responsibilities, and they have to figure out a way, we try to help them figure out a way to deal with their differences, a strategy. You know, typically it's usually sometimes I win, sometimes you win, sometimes we compromise, and a place to talk about their differences about their children. That's really important. And in very high conflict families, then we get them to agree to put aside their differences. So the typical example are a divorced couple who may have a lot of negative feelings about each other. And we just ask them, and again, most parents can do this, to put that aside while you're in therapy with us, and let's work together as a team for the sake of your family and your children. And most people will do that. And so teamwork, defined broadly, is very, very important first step. And then we're going to have them, usually there are going to be some obvious things that the parents are doing. The teen will often tell you, you ask, and they tell you that it's an attempt to influence their teenager, but it doesn't work. And I'm a parent too, we all do these things. So it's yelling excessively, nagging, name calling, lecturing, or I often say giving good advice, but it's usually not experienced as good advice, or even, you know, at the other end, real harshness, taking the bedroom door off, locking them out, all the way to physical violence. And so we need to inquire about these practices, and I say we're a family therapy, so usually you see it sometimes, and the teen lets you know, and you're going to work right away, and we have specific techniques in MDFT to help the parent stop or reduce these practices that aren't working and are turning their kid off. And the basic idea is you go through, you know, the yelling, the nagging. Does it work? Do you get what you want from your teen? And usually not, or it works a little bit, but not completely. And, of course, when the parent is yelling or lecturing or nagging, usually the parent feels awful inside, very stressful, and it's not working. So it's kind of logical. You say, why do something? I understand why you're doing it, always understand, but why do something that doesn't get you what you want and makes you feel terrible? So let me help you, you know, give some tools to stop doing that. And what we're going to do is we're going to put in place practices that will work better. And most parents, it's amazing. They're going to see it. They're going to agree. And, again, we have tools to help them stop. And this is usually a change we can make very quickly. And what's kind of wonderful about this is then you bring it up to the teen alone at first, and then have you noticed, is your mom yelling less, nagging less? Oftentimes they don't notice at first, and then you keep with it, or you bring the parent together and say, well, now come on, you know, I remember that time when you did that, what would I typically do? And then this also gives the teen confidence in the therapy's ability to make changes in their parents and not them. So it's really important, and it's usually something we can make happen very early on in the treatment. We're going to help them look at their parenting practices and enhance age-appropriate parenting practices, help them decide on house rules, expectations, help them choose their battles, talk about incentives and consequences, not just, and help them figure out ones that will be workable, develop an action plan, and the idea, once they've come up with their new rules and they've got incentives and consequences, we always say we're going to do this, let's experiment, right? We don't know what will work, you'll try it. If it doesn't work, we'll sit together, we'll come up with new ideas. It's very important. A lot of families, you'll notice, parents will say, oh, he knows, he just has to do the right thing. He has to act responsibly. He has to respect me. But when you probe, they don't give real details of what the teen would be doing that the parent would say he's acting responsibly. And the teens need details. They're not going to be able to follow the parents' rules and expectations if they don't know specifically what they want. And so we work with the parents to help them be very, very specific so the teen at least has a chance to comply. It's important to have incentives as well as consequences. And the choose the battles, I want to spend a moment on this because our kids, they come in, you know, they're having a lot of problems. They're using drugs, they're not going to school, they're getting arrested, they're coming home at 3 in the morning, or they're not coming home. Those seem to be the big things. But sometimes you'll talk to a parent and they'll put in the same level of importance coming home at a reasonable time, not swearing at their mother or father, with picking up the wet towel after a shower. And so we, of course, if the wet towel is important, but we're going to challenge them to choose your battles and perhaps start with the really important things and then move to these others. Now, some parents, the wet towel is as important as stopping using drugs. And then the MDFT therapist, after they challenge a little bit, we're going to respect the parent. And if that's as important, then let's make it clear what you want and the consequences and incentives and so on. So this takes some time, and everything doesn't have to be in place when the parents start taking action. They may just be sure about 1 or 2 new house rule, or clear about a new, and as I say, it's an a give and take process, very experimental until it works for the parent and the team. We're going to help the parents communicate in a new way with their team. Most parents have a hard time listening to their team, and we want to, as I mentioned earlier, we're encouraging the team to talk to their parents. We're going to do this in family sessions, but we have to get the parents ready to listen. And basically the thing we say is, usually I say to the parent, look, there's no light between you and me. You want your child to go to school, to be respectful, to stop using drugs. I completely agree. I'm with you. But you're not going to get there if you don't know what's on his mind and in his heart. And if you want to influence him, if we together want to figure out how to get him on a better path, we've got to understand what he's thinking and feeling. And so I'm going to ask you in family sessions, even if he says things that are wrong, you know, that push your buttons, and many of the teens might, let's hear him. Let's understand him first, because a teen is more likely going to comply with you if he feels heard and understood. And the more you know him, that you'll have better ideas about how to influence him. Every parent, when you talk like that, is going to say, okay. Oops, skipped. Now we're going to play a video. This is a judge in Miami. Actually, he's the chief administrative judge of the juvenile division and the drug court judge. And he talks about MDFT and its approach and his experience, because he makes a lot of referrals to MDFT.
By the time they get to us, the parents are at the end of their rope.
So the judge there does talk about the family approach, and he's absolutely right. In MDFT, it's not just, we're working not just for when they're in therapy with us or in drug court, but the main focus is on beyond. And one thing that's really interesting in many of our studies, we find that after treatment, the symptoms continue to reduce, drug use and mental health and school grades and so on continue to increase long after therapy, so that 24 months after therapy, the child is using even less drugs than he was using at discharge from treatment. And or the gains made in treatment are maintained. And it's really interesting if somebody mentioned about alternative treatment. So we compared MDFT with individual cognitive behavior therapy, which is a very good, powerful, effective treatment. And we found in a couple of our studies that from intake to discharge, if you look at substance abuse, both treatments, CBT and MDFT, significantly and dramatically reduced drug use. But when we looked 12 months, 24 months later, the teens who got cognitive behavior therapy, individual therapy, their drug use went up as high as what they were at intake, higher, maybe a little bit lower. But in MDFT, the drug use stayed low as at discharge, or continued to decline. And we think, our theory is, because in MDFT we're changing the parents and the family as well as the youth. And then the family and the parents have been changed in such a dramatic way, transformed, as Dr. Cindy Rowe said, that they're able to maintain the treatment gains. They, in a sense, become their own therapists. They can take care of themselves. And so it's just marvelous to think about that. And the family domain is very important. I mean, all domains are, but of course we're known for our work in the family area. So what do we do there? Now, this is my favorite slide. Everybody has different favorite slides. This is my personal favorite. Here's the deal. We call the shots when you're young. You call the shots when we're old. And everything in between is a nonstop battle for control. I think that's family life. So what are the goals? Pretty simple, although often complicated to achieve. Is we're trying to improve family communication and problem-solving skills, how they talk, how they listen to one another. We're going to strengthen emotional attachments and feelings and love and connection, because that's the glue. It's all about that. And we're going to improve everyday functioning of the family unit. Now, how do we do that in MDFT? We do that through the intervention, classic family therapy intervention called enactment. And enactment is all about experiencing each other in a new and different way rather than talking about it. And it's experienced right in the therapy room. And the therapist sets up a situation and coaches and intervenes so that the family members can hear each other, can say what's really in their heart, and can have basically just a healthy way of talking to each other, of being with each other, of thinking about each other. And it happens right in the therapy room, and it is impactful. So we're going to have people, and enactment is just facilitating conversations, healthy, productive conversations between parents and youth. It's as simple as that. And we're going to have the parents and youth express their opinions, complaints, concerns, desires to each other, again, in a way that's real from the heart, and you're not cut off, and also without the blaming and the criticizing that usually we turn each other off. We're going to help everybody listen to each other and restrain their inclinations to interrupt, disagree, or judge until people have had a chance to be heard. We're going to help them respond in constructive ways. They don't always have to agree, of course, but we want to help folks acknowledge each other's point of view. And we're just going to facilitate healthy conversation, talking, listening, thinking, moving on, problem solving. Common topics for these conversations are new expectations, monitoring, incentives, consequences. So we talk to the parents, we help them get clear about how they want their family to run, and then we have to bring them together where the parents have to tell the child or children, well, this is how it's going to be, you know, this is what I want from you, Here's the incentive. Here are the consequences. We want to hear the teen's response to that. They may get all upset. That's not fair. This is why. We're going to help the teen express to their parent as clearly as they can why they disagree with their rule. And the parent might say, I understand your disagreement, but this is important and why, or they might listen and change. We're going to help this conversation be very natural and organic. This is really important, a little tip with when the parents lay down the New World Order. It's very important that they not only talk about the new rules and consequences and incentives, but say to the child, the teen, why we're doing this. And the reason for why has to be what it always is. I'm doing this because I love you. I want to protect you. I'm not going to let you ruin your life. I'm not going to let you end up in prison. And this is what I believe will help you. So the child must know that the parent isn't doing it to be mean and to make their life miserable, but they're doing this out of love and protection and not allowing them to ruin their life. The teen is much more likely to go along with the new rules if they understand the motivation behind it. And the parent cannot say this enough to the teen over and over. Another area that often happens in the family are resentments, hurts, pain of the past, trauma. Many of the children, not all, are mad at their parents for some perceived or real betrayal, hurt from the past. And until in MDFT, until you deal with whatever that is directly between them, the child will not accept the parent's parenting. So they could have the most reasonable rules and consequences and stop nagging and so on and so forth. But if there is this resentment in the child and they haven't addressed it, then the child basically says to the parent, you've lost the right to parent me. And this can be from a simple thing as being misunderstood to feelings of you choose stepdad over me all the time, you love my brother more than me, you blame me for everything, you abandoned me, you left me with grandma for 2 years, all the way to, physical and sexual abuse. It must be dealt with, and we in MDFT have an important ways of dealing with that. Other issues are what to do about continuing problem behaviors. People try new practices, not working. Issues of trust and mistrust are very important to teens as well, and there's other issues as well. Common session goals are deeper understanding, improved skills, more connected, and an action plan for moving forward. The third, I'm going to rush a little bit because I want to leave time for questions, but you'll have the slides and you can look at them. But the fourth domain is the community domain, and that's basically where we help the teens and parents negotiate important relationships with school, court, neighborhood, learn how to advocate for themselves, reduce barriers to participation in treatment and success in treatment, obtain necessary services. Often for teens, it's getting involved in pro-social recreational activity, sports, maybe going to 12-step meetings. It's a variety, very individualized.